and share my screen. Oh, there we go. And thank you again. So today's topic is problems with posteriors. And by the way, I'm talking about posterior infarction, that is. So really important, first and foremost, we're going to talk about our first patient who came to our emergency department on 4/15, 54-year-old man, no past medical history, really hasn't had much health care in the past. He does actually have hypertension when he's first seen here in the ECC and in EMS. But what was really, really important is that related to his examination and his presentation, the type of chest pressure that he was feeling, that he was diaphoretic, that it was front to back chest discomfort, which oftentimes actually is a presentation for an aortic dissection. And there were some concerns, the differentiation for aortic dissection versus pulmonary embolism versus acute coronary syndrome. Not really certain about what's occurring. ECC resident is the first person that is writing a note, says, I'm going to give him some aspirin, give him nitro, I'm going to give him fluids, get a stat chest x-ray, stat EKG, troponins, BNP, CBC, UA, everything possible that I can order. And I've asked for a cardiology consult, but they want to wait until there's an EKG seen. And the ECC resident also writes, I anticipate admission. So as soon as the EKG was seen, the resident actually asked for a cardiology STEMI interventional alert, communicating with Dr. Taha. Dr. Taha was not in the hospital. It was 10:30 at night on 4/15, but Dr. Taha is going to come in to perform an evaluation in the cardiac cath lab. So now you take just a quick look. I did not give you his diagnosis because I want you to look at him before I do that. His heart rate is 64. He's in a normal sinus rhythm. He has a left axis deviation with a narrow QRS. Now, anybody who's been attending any of my programs of late, especially left bundle branch block, right bundle branch block, we're going to remind ourselves that we always look for direction of the current of the heart. Does it go to the left, which is the normal direction, and how much time does it take? And it should always, your QRS width should always be less than 0.11. So he has a nice narrow QRS, has a left axis deviation, but his current is going towards the left. He has a normal QT corrected interval. Remember, the QT corrected is corrected for the patient's heart rate, but it's the same strategy, just being sure that the T wave is complete by 480 milliseconds, whether it's corrected for heart rate or not. We always say 480 milliseconds is about the top level that we're really going to tolerate well. And typically we don't do anything until the QT interval is greater than 510. STEMI alert is activated and his point of care troponin is 1.22. Now, really important here to look at point of care troponin in this patient. Point of care troponin is our historic method of looking at troponin. Everybody needs to remember that we look at troponin in two ways today. We look at troponin in our standard way, which is what this is, and that is in nanograms per milliliter. But high sensitivity troponin, which is exactly the same troponin, it's evaluated in the same way, but it is referenced as amount of troponin in a liter of fluid. So one is a mil and one is in a liter. High sensitivity troponin is 1,000 times the point of care troponin. So what that's telling you is his high sensitivity troponin, which is what we use today, is 1,220. So a very elevated troponin. Normally men have a troponin less than 15 high sensitivity. And if we're looking at standard troponin, less than 0.04. So in any case, one can see the troponin level is high. Now, troponin elevates whether or not you're having an infarct. It elevates for a lot of purposes and a lot of reasons. That's why in the emergency department, it is absolutely essential to get the first troponin at hour 0, meaning as soon as you've identified the patient might be having a myocardial event, that's hour 0. and then drawn 1 hour later, the second troponin, because if patients are actually having an acute coronary syndrome event, they will have an expanding troponin dump into their system. That's why we do one at 0 hours and we do the second one at 1 hour. In hospital, we do 0, 3, and 6. But in the emergency department, where we don't know the patient, we don't really have a history, we don't know what's occurring, we do 0 hour and 1 hour. And for all nurses who work with emergency room patients, it's really important to remember that that level has to be drawn at 0 hours, and then another level has to be drawn at 1 hour. We don't draw them both at 0 hour and call them 0 and 1 hour, which is oftentimes what happens. And part of that is just related to staffing, and part of it is probably related to education. So we just want to remind ourselves, we're going to use troponin as a platform, and we're going to look at whether or not you have a significant increase in your troponin over a 1 hour period of time. That's going to tell us whether you actually have an acute and expanding event. Okay, so what would you say to this EKG? If you looked at this EKG, what would you think about this EKG? Now, I'm going to just give you a second to take a look at it. I'm not going to give you the answer right now. I want you to be looking at this and making some decisions in your own mind about what your concerns are. And you might be identifying some concerns, but not really being able to label them. And that's also okay, as long as you can identify some concerns. So really, really important to appreciate what you would say to this EKG. You're the nurse looking at it. Your physicians haven't looked at it. It's been loaded to TraceMaster, but you are the one who really needs to identify, do I need a provider to look at this right now? Should we be calling cardiology to take a look at this EKG? It seems like it might be an unusual EKG. I'm not really sure what's wrong. And again, if you've been with me over the last few weeks, you know that I talk about first do axis, then look at R-wave progression, and then ultimately look at leads and lead groups in order to designate whether you see ST segment elevation or ST segment depression. And I'm pretty sure by this point, you all can say, oh, look, you've got a lot of ST depression here. So, and you got a little bit over here in V4, you got V1, V2, V3, very significant ST depression. Well, by the way, ST segment elevation in V1, V2, V3, and V4 has to be typically in terms of what we consider to be abnormal, at least 2 millimeters elevated, and in the absence of left ventricular hypertrophy or left bundle branch block. But ST segment depression in chest leads is always cause for concern, always an emergency. And you can see you've got ST segment depression. Now in your limb leads, so that would be 1 in L for the lateral wall of the heart and 2, 3 in AVF for the inferior wall of the heart. In the limb leads, ST segment depression of 1 millimeter or more can be considered significant. So you can see you actually have a couple of problems here, and we're going to talk about what they are. We're going to name them. We're going to be comfortable. We're going to be able to discuss it, and we're going to be able to advocate well for our patient. So I do want to show you very nicely, almost exactly right, because at 2257, that would be hour 0, high sensitivity troponin, which would be 1.4 in old troponin, is 1,471 in high sensitivity troponin. And almost 1 hour later, a little bit longer, right? This is almost 12 midnight. And at 1:30, a second troponin is drawn. So it's almost an hour later. It's a little bit late. You now see the delta. The delta is the amount of change that occurs. So we ask that actually to say that you're actually having an expanding acute coronary event, you have to have at least a 5% change. So 5% of this would have been 70, but look at how much the patient has increased his troponin, 26,224. Now, what that's telling you is a lot of his myocardial tissue is at risk, and he's spilling intramyocardial cellular contents into the blood. That's what the troponin is. And it's specific for cardiac tissue, although you do see it sometimes with renal dysfunction. It's really quite particular for cardiac tissue. So we've had a huge delta. The delta is the change between the two, which so significantly and profoundly actually points to an acute coronary syndrome event. And you see a couple of other things that are worrisome. Certainly the fact that his lactic acid is elevated, is 3.9. We have concerns about that. We have concerns about the patient's potassium. Is this from renal dysfunction? Is it from metabolic acidosis? Is it from an endocrine dysfunction? Or is it because he's lysing cells? So at this point, we don't really have that answer, but we do know it's probably not ketosis, because his glucose is 130, although it could be ketosis, could be normal glycemic ketosis. And don't really think it's renal failure because his creatinine is 1.1. So I'm going to look at that and say, maybe there was a problem with the lab draw, and that might be part of the issue. So that's one thing we're going to think about. Maybe a problem with the lap draw. Maybe it was drawn from an IV and sat around for a while and we had some hemolysis. Or maybe we have a lot of muscle wasting. We're not sure yet. And right now, that's not our biggest worry. Our biggest worry is this delta in his HS troponin. So first and foremost, you got to know your vessels. Got to know your vessels. I talk about vessel structure a lot, probably ad nauseum to people. But just to remind you that you have two major coronary arteries, the left main, which comes off of the left cusp, the bowl around the valve of the aorta, and the right coronary artery, which is the right main, the left main and the right main coming off of the aortic valve. The left main quickly bifurcates into the left anterior descending and the left circumflex, and the right coronary artery has lots of tributaries, but it still stays the major branch with tributaries. So important for us in knowing of our vessels is to appreciate the left main coronary artery, the left main coronary artery, which then bifurcates into the LAD and the circumflex. So the LAD goes down the front of the heart, the circumflex goes around the side, and the right coronary artery, which supplies the whole right ventricle and the true posterior wall of the left ventricle. Aha, she said the word posterior, and that is really important because the left main bifurcates into LAD and circumflex, and our focus today is the circumflex. The circumflex supplies the posterior lateral wall. Okay, that's really important because I might be looking at an EKG that has lateral changes, but it may also involve the lateral posterior wall. So if you just take a look at the circumflex here, it circles around the back of the heart and gives rise to the posterior lateral surface, supplying the back wall, the lateral back wall of the left ventricle. And also, which is really, really important to know, is it supplies the papillary muscle of the mitral valve. And that is incredibly important. As well, it gives rise to the sinus node, 45%, not half, but almost, and 10% of the AV junction. The right coronary artery, so most of us talk about the right heart, it's a weak muscle, it's not that important, although we know that's not true. We know the right ventricle is really important in survival from critical illness and the ability to perfuse the pulmonary vasculature with blood. So it is really, really important, that right ventricle. But because the muscle is thin, it doesn't have as high an oxygen demand, there's less branches. So the right coronary artery actually has a tremendous amount of responsibility. Look at that list, a huge list of responsibility. And the right coronary artery supplies the right ventricle and, by the way, the true posterior wall. So posterior wall of both right and left ventricle are supplied by the circumflex and the right coronary artery. And in general, folks don't worry as much about circumflex or the right coronary. They worry a lot about LAD disease. But it is really important to appreciate that the right coronary artery supplies the true posterior wall of the right and left ventricle, and the right coronary artery supplies the right ventricle. Now, that's really important because when we talk about what those vessels supply and what leads we use to evaluate what's being threatened, it will become really, really clear. So in knowing your vessels, right, I'm not asking you to memorize everything. I'm not asking you to be an EKG expert. I've struggled my whole life with EKGs. I still struggle. I look at them every day. I talk about them. I evaluate them. I'm practicing all the time. 10 cardiologists, 1 EKG, 10 different opinions. That's the way it works. I want you, though, to recognize and to understand both the anatomy and the physiology. So remember that circumflex, that actually supplies the lateral wall and the posterior lateral wall of the left ventricle. So when I see lateral changes on the EKG, I immediately think the possibility of the posterior lateral, which is difficult to see and requires some investigation. The right coronary artery supplies the inferior wall, the diaphragmatic wall, the bottom of the heart that sits down on the diaphragm side. And it also supplies the true posterior wall of the left ventricle and the posterior third of the septum. So really, really important, because when you have a high degree right coronary artery occlusion, you may see an infero-posterior, and you may even have some lateral extension. Infero-lateral posterior MI. Now that means your patient is at risk for profound cardiogenic shock, for dissection, for rupture, for mitral valve papillary muscle rupture, because it supplies that posterior third of the septum. So it's actually the posterior septal valve leaflet of the mitral valve. And this is really incredibly important, because when we look at the EKG doesn't look that bad, but the patient looks terrible and he's progressing rapidly into cardiogenic shock. And we're like, what's happening here? The EKG doesn't look that bad. Now, in this case, that patient's troponin was a real clue. Sometimes it's not quite that high, but this was a really high troponin, and it evolved very quickly in 1 hour. So really, really important for us to appreciate that. And then we put that together with knowing our segments and our waves. So I know everybody knows how to label an EKG, but it is really important for us to understand wave labels. So always on an EKG, you look for an upright indicating ventricular depolarization. Now, what that means is current is coming towards the electrode of choice. So that could be V1, it could be V6. Just that current is coming towards the electrode, and that instills an upright. If you have a downward wave before the upright, that's called a Q. If you have a downward wave after the upright, that's called an S. Isn't that funny? P, Q, R, S, T, alphabetic, right? But always find your R wave first on an EKG, then look in front for a Q and look behind for an S. And I want to make sure we appreciate, it's really not normal to have Q waves, even though we always say QRS. Really, Qs are normal only in the extreme left-sided leads. That would be 1L, V5, and V6. And they are normally less wide than 0.04 and less steep than 2 millimeters. So I'm always looking at Q waves when I'm trying to make some good decisions. Remember, if current goes away from the electrode, the direction will be downwards. If current comes towards the electrode, the picture will be upwards. And that's the way we're going to look at EKGs and talk about, should the current be going towards the positive electrode of V6? Absolutely, it's on the left side. Should it be going towards the positive electrode of V1? Absolutely not. That's the right side. Should always go away from the right side in the normal projection. And then we just want to remind ourselves about the ST segment. The purpose of the ST segment is to allow electrical rest. So all your ventricular tissue has been depolarized, all depolarized equally, and it's resting electrically. What's happening during ST segment is electrical rest. Anything that disturbs the oxygen levels of the myocardial cell will cause electrical unrest. And that's what we would call ST segment elevation or ST segment depression, depending on what's happening for the patient. You always expect your ST to be at the theoretic baseline. Theoretic baseline is defined by the T to P interval, that line before the P wave, straight line over. ST segment should be at that same exact straight line. There should be no deviation whatsoever. It shouldn't be upward, shouldn't be down. Things cause deviation that are not STEMIs or non-STEMIs. Lots of things cause deviation, pericarditis, myocarditis, all sorts of stuff. But for our purposes, the very first thing we want to do, we want to make sure that your STs are normal. So that's a really important. Remember, ST segment is electrical rest. During electrical rest, you have mechanical contraction, but that's mechanical. It's not electrical. Electrical rest, all cells should be depolarized equally, and there's no shifting current between the cells. So the baseline, the ST segment, should be at the electrical baseline. And that's defined by the TP interval. That's the straight line before the P wave. Okay. T waves, really, really, really important. Such a beautiful term that we use. T waves should go in the direction of the majority of your ventricular depolarization. So that means here you can see it's all upright. You got two little downwards. Everything else is upright. That's the major depolarization is upright. The T wave should also go in that same direction. If my primary direction was downwards, I'm going to expect the T wave to also point downwards. That is known as concordance. That means it's synergistic. Upright QRS, upright T wave. If you have an upright QRS and a downwards T wave, something's wrong. If you have a downward QS wave and an upright T wave, something is wrong. So always expect concordance, and non-concordance identifies that your patient is having a problem. There are many problems that cause this abnormal concordance, but for us today, we're going to use this in the evaluation of EKG. So you want to know your segments and your waves because, of course, when we're talking about the EKG, very first thing is we're going to look for ST segment, in this case, ST segment elevation. Now, ST segment elevation is seen when you're threatening a large portion of the myocardium. And if I put a lead directly over the area that's being threatened, like the anterior wall, I put a lead over the anterior wall, V3 or V4, I expect to see ST segment elevation. If I put a lead on the back of the chest and I had ST segment elevation in the anterior leads, V3 and 4, I would expect to see ST depression in the posterior leads, V7, 8, 9. You don't use posterior leads, although you should be using them. I think you need to be using them, and hopefully you will after hearing this talk. So really, really important to remember that when you threaten enough of the myocardium, you're going to see electrical changes on both sides of the heart. So let's just say this is your lateral wall. Here's your inferior wall. In the lateral wall, I have ST segment elevation. That will be reciprocated in the inferior wall, which is opposite, with ST segment depression. So very important for us to appreciate that when you have ST segment elevation, whether you see it or you don't, that you are threatening the full thickness of the myocardium, and this is dangerous. There's a lot of cardiac muscle being injured here, and once that tissue is dead, you will not be able to resuscitate it, which is why time is of the essence to reperfuse the coronary arteries in whatever way you can. Here at Grady, it's going to the cath lab, which is really lucky. Aren't we lucky that we have that capability? So in a STEMI, you have ST segment elevation. In a non-STEMI, you have ST segment depression and ultimately inversion of your T wave. Now, remember what I said. You're upright with your R, but your T wave is in the opposite direction. That's not a good thing. That's not supposed to happen. Your T wave should always go in the same direction unless you're having an event. Okay, fantastic. So we know there's lots of changes that we have to be aware of. We look at T waves very early in a process as patients are occluding their vessels. The T waves will get really big. They'll get really, really tall. And then you'll start to see ST segment elevation. After that, so your T waves get tall, your STs elevate. Now you start to lose electrical conduction tissue and contraction tissue. And once you start losing electrical conduction tissue, if I have a lead on top of that area, again, I'm just going to talk about the anterior just because it's easy, V3 or V4, now all my current is going away from that area. That's what gives me a pathologic Q wave. Pathologic Q wave, wider than 0.04, deeper than 2 millimeters. Tissue's already dead and it's still dying. So long as I have ST segment elevation, I am threatening the myocardium. And my goal is to limit the amount of myocardial loss. So we go back and look at that patient just based on his troponin. Just based on his troponin, he was losing myocardial cells head over tail so rapidly. He went from 1,400 to 27,000. He was losing cells rapidly. So our purpose here really is to talk about that acute event. But as time goes on, you resolve STs, your T waves invert, and then they come back to normal. And you can still have a Q wave because you've got dead tissue, but now you don't have ST segment changes and you don't have T wave changes. ST segment changes tell us that we are in process. So when I have ST elevation or ST depression, I have to appreciate that that's telling me that my myocardium is in process. And my goal as an advocate is to identify it, to call attention to it, and to try to stop it. I may not be able to name everything that's wrong with an EKG, and that is okay. But I'm looking at a patient who's got 10 out of 10 chest discomfort. He has an abundance of troponin in his serum because he's wasting cells, and he has an EKG that looks to me to be quite abnormal. I can't identify what it is. I have a responsibility to drop everything else and find my provider, find my physician, find my APP, find my cardiologist. That's my responsibility. So really, really important just to look at this visually. MIs evolve. And the reason we do serial EKGs, so your first EKG, you didn't have many changes, but you still have chest discomfort and your troponin is elevated, you're getting another EKG. You're going to get another EKG at 30 minutes, no longer than an hour, because EKGs evolve. And remember, at first, what we might see is very subtle ST segment elevation, but a very hyperacute T wave. A hyperacute T wave is greater than half of the R wave. And then we see ST segment elevation. And then over time, that ST segment elevation starts to come down and the T wave inverts. That's in the process. That time might be 30 minutes. It might be 15 minutes. It could be 2 hours. Then my ST segment flattens. The acute process is over. Tissue is now dead. See how I didn't have a Q wave here, but I've got a Q wave here. Tissue's dead. Dead tissue. Can't resuscitate it. It's already dead. Right? So my goal is to try to limit the amount of dead tissue that occurs, because once I've killed those myocardial cells, they are not going to regenerate. Now I've got a big hunk of dead cells which don't participate in contraction, which then means my ejection fraction is low, and that puts me squarely in the arms of heart failure. And the worse your heart failure is, the more likely that your life is going to be difficult. Really difficult. So remember, serialization of the EKG is really important. And if you have a question, because the patient's pain is ongoing, try to get another EKG, do it yourself, ask for it, get it done, get it done. Make sure you're doing the troponins in a timely manner. Troponin plus EKG plus patient complaint actually is the best diagnostic tool we've got. Now, I want you to know your lead group. So it's not a 12-lead EKG course, but I can't talk about posterior infarcts without talking about lead groups. So first and foremost, knowing your lead groups, 2, 3, and AVF share the same positive electrode. What changes is the negative electrode, so the direction of view. But all 3 of these leads look at the inferior wall of the heart, inferior foot, so down on the bottom of the heart. V1 and 2 view the septal wall, the anterior septum. V3 and 4 view the anterior wall of the left ventricle. And 1 and L, both positive electrodes up here on the left arm, positive electrode is here, the negative electrode is the one that changes, actually view what we call high lateral, and V5 and 6 view low lateral. Now, low lateral tends to be involved with circumflex lesions. So a lot of times with somebody who's got a circumflex occlusion, I might see ST segment elevation V5 and V6, and also possibly in 1 and L. And if that patient isn't responding the way I think they should, I'm going to want to look at their posterior surface. Okay, so just correlating them visually for you. 2, 3 and AVF inferior, 1 L V5 and 6 lateral, 1 and L high lateral, 5 and 6 low lateral, V1 and 2 septum, V3 and 4 anterior. Now you don't see anything here that talks about posterior, and that's because in general we don't put leads on the back of the heart, but we refer to the back of the heart by the reciprocal changes that we can see in V1, 2, 3, and sometimes even to 4, depending on the surface area involved. AVR is an incredibly important lead, but for our purposes today, we're not going to talk about AVR, but it is a really important lead when we're talking about 12-lead EKG monitoring. Lots of times you'll go to classes, hear people say, don't worry about AVR. No one cares about AVR. Oh, that's not true. CTO causes changes in AVR. Right bundle branch block is evaluated in AVR. RV hypertrophy evaluated in AVR. AVR is pretty important, and it's really unusual to see ST segment elevation there. And if you do, something's really wrong. Okay. All right. So know your leads and your lead groups. And very, very important for us to appreciate that we talk about lead groups that face an area of the heart. B1 and 2, the septum, B3 and 4, the anterior, 1L, 5 and 6, lateral, 2, 3 and AVF inferior. And if I put leads on the back of the chest at the 5th intercostal space going across the back of the left chest, those would be posterior leads. So just ignore posterior for a minute, just right here, just ignore that. And let's just talk about that V1 and V2 is facing the anterior septum, but it's reciprocal to the posterior wall. Reciprocal to the posterior wall. So you see that down here. Facing the posterior wall, V7, 8, 9, reciprocal V1 and 2. So let me just say one thing here. When you have an inferior MI or when you have a lateral MI, always look to posterior reciprocals, because it's highly likely that you'll have either posterior lateral involvement if you have a 1L, V5 and 6 changes, and it's highly likely that you'll have a true posterior change when you have 2, 3 and AVF changes, inferior changes. And that's what's so incredibly important. So it is of note to just remind ourselves that RCA occlusions typically end up with RV infarct, and they can also cause a posterior infarct. That's an RCA occlusion. So the first thing you see is that it's inferior. And if we were really grinding down, we would say ST segment elevation in lead 3 is bigger than in lead 2. And what we typically see here with a true RCA is ST segment depression 1 and L, because that's reciprocal. Whereas with a circumflex lesion, the ST elevation lead 2 is bigger than that in 3, and you don't have reciprocals because it's a circumflex lesion. So your lateral wall is involved with ST segment elevation. So that's kind of down in the weeds. It's so important. All I'm saying to you, really all I'm saying is, if you have inferior changes, think about posterior. If you have lateral changes, think about posterior. Let me revise that. If you have inferior changes, think RV infarct and posterior. And if you have lateral changes, think posterior. That's a big muscle surface. And when patients lose that, they really deteriorate rapidly. So this is an RCA lesion. And so if we just take a look at lead groups, we're going to start with 2, 3 and AVF. And in 2, 3 and AVF, you have ST segment elevation. And you'll see that in AVL, you have ST depression and you don't have ST changes in 1. This typically looks like a right coronary artery occlusion with an inferior change on EKG. Now here you have a circumflex lesion, and it also is giving you inferior changes, but the inferior changes are a little bit different here. With the circumflex lesion, you see that your ST segment elevation, loss of your R wave, is bigger in lead 2 than it is in lead 3, and you have ST segment elevation AVF. And you don't actually have what I would have wanted you to have would have been ST segment elevation in 1, but you do have a little bit of elevation over here in V6 and V5. This is a circumflex lesion. And I only know that because patients went to the cath lab. Now, 40 to 50% of all MIs that come through our ECC that get admitted into the hospital are inferior STEMIs. If you have a standalone inferior, you have the best possible prognosis. Most of those patients don't go into cardiogenic shock. They do pretty well. Very few of them have cardiac arrest in the hospital, but 40% actually have a right ventricular MI in association with the inferior MI, which means that their prognosis is significantly worse. If they also have bradycardia, which means that they have a high-grade occlusion in the right coronary artery, they've infarcted the sinus node of the AV junction, that increases their mortality by 20%. The RVMI increases mortality 40%. If you have a posterior infarct, it increases mortality 60%. So this is why it makes sense for us to have an understanding Okay, so now let's take a look at this patient. So this is our patient. This is our patient that I started with. This is our patient with an inferior, asking you if you had an inferior. So remember, we're going to start with lead groups 2, 3, and AVF. You have just a little ST segment elevation. It's very subtle. It's only about 1.5 millimeter, but you've got it in lead 2 greater than lead 3, which typically means that you have a circumflex lesion. And by the way, I look at 1 in AVL, and both of those have ST segment elevation. 1L, V5, and 6. In V5, no ST segment elevation. In V6, a little bit of elevation. But what's really standing out to you is ST depression in V1, V2, V3, and V4. A major muscle mass involved in the posterior surface. This patient is having an acute posterior lateral infarct. And without somebody really looking at him and moving him forward, he would have died. He didn't, because you did such a great job in the ECC. So just reminding ourselves that when we talk about inferior MI, we talk about 2 different kinds of inferior MI, one associated with circumflex lesion, the other associated with RCA. Why do you care? Circumflex supplies the posterior lateral wall, and the right coronary artery supplies the right ventricle and the true posterior wall. Now, the problem with these patients is that they aren't often getting diagnosed as having an RV infarct. But let me tell you one of the ways you know it. If you give them nitro or morphine, they're going to bottom out their blood pressure because they've infarcted the RV. They can't handle any venodilation, which removes volume from the right ventricle. So they're going to bottom their blood pressure. You gave them a nitro, and now they've almost arrested and they're almost atensive. They're going to get fluid. They frequently will become hypotensive when you give morphine or when you give any kind of nitrate. So we don't ever do that with somebody who has an inferior MI until we are sure they have not had an RV MI. And the RV MI is something you'll suspect, particularly if the patient has 1st degree or 2nd degree block when you're first evaluating them. Okay, so always consider RVMI in the patient who presents with an inferior MI. Very important to remember that they have to have a big RCA occlusion, and it needs to be close to where the right coronary artery arises. That's at the cusp of the aorta. So with inferior family MIs, I love that term, I'm going to always look for that possibility of an RV infarct. And what that means is that I'm going to ask my EKG tech to do a right-sided EKG. Okay, so a right-sided EKG, the tech just leaves 1 and 2 in place, and they take all the left-sided leads, 3, 4, 5, and 6, off of the left chest and put it on the right chest. In the exact same positions as it was on the left, we're going to put it over here on the right, okay? And what we're going to do with those right-sided leads is all we're looking for, the only thing we're looking for. So here's a patient with right-sided V4, V5, and V6. V1, V2, and V3 doesn't really matter that much, but V4 and V5, you can see you have some ST segment elevation. It only has to be modest. It doesn't even have to be a 0.5 millimeter in that right side EKG to tell you you've had a right ventricular infarct. All you need to do is ask the tech to do a right-sided EKG. They'll do it for you. They need an order, but they'll do it for you. They'll take the leads off, put it on the right. They'll mark it there. You'll need to mark it on the paper when you take it to the doctor. And the thing is that RV infarct signs don't last very long. So you want to do that early on in your process. Look at that sensitivity. 88% sensitive, but more importantly, 78% specific, unlike almost everything else that happens on an EKG. This is sensitive and specific, looking for ST segment elevation, 0.5 millimeter, 0.5 box on the right-sided leads. That's what you're looking for. Pretty straightforward. Don't have to know everything to appreciate that. Okay, so now again, we look at this patient and we say, oh, look, I don't even have to think much. 2, 3 in AVF, really significant ST segment elevation. ST segment elevation is greater in 3 than it is in 2. That typically indicates, again, that we are having a right coronary artery occlusion. I see that I have ST segment depression in AVL and in lead 1. That's probably purely an RCA. And then reminding myself that if it's an RCA lesion, I have a likelihood that it will be right ventricular infarct. So I look over here at V4R, that's the most significant one, and you can see I've got ST segment elevation. My patient's having an RV infarct. I'm gonna lay on top of that bed. No one's giving this patient morphine. No one's giving this patient nitroglycerin until I have volume loaded the patient. And that's unusual for us because normally with an MI, with a STEMI, we're not wanting to give volume, but with an RV MI, that's what's going to save your patient's life. Okay. So again, ST in 3 bigger than in 2, ST depression in lead 1, that ensures that this is an RCA and not a circumflex lesion. Okay. And again, this is V4, 5, and 6. This is not the right-sided lead, but it looks like you've got extension from the inferior wall into the lateral wall, low lateral wall. Okay, now I'm going to give you a different patient. This patient was, I've already presented this patient before. Admit on 2/27/2022, came to the ED as a STEMI alert, hypotensive, got aspirin. He got some IV fluids that improved his blood pressure. Okay, all right. Now you, right away, somebody drops their blood pressure when they're having an MI, you should always start to think that it might be right ventricular infarct. EKG wasn't really significant, but the patient had RV dilation on his bedside echo, his POCUS. And so they took him off to emergency CT to look for dissection, to look for PE, but there was no large embolic event. Patient wasn't dissecting, had lots of PVCs and a couple runs of ETAC. Point of care troponin is 0.11, which is 1,100, very elevated because of the troponin, because of his presentation, and because of his abnormal rhythm, even though his EKG wasn't profoundly abnormal. They took him urgently to the cath lab. Now, if I'm looking at this EKG, I think it's pretty significant, okay? I'm looking at his EKG, and what I'm seeing here is a little bit of elevation, about 1 millimeter here, about 1.5 millimeters here, and can't really tell what's happening there because I have a lousy EKG. By the way, I would never accept this EKG from my tech. Too much movement and a lot of dysrhythmia. I need a better EKG. I need a rhythm strip that's longer, that doesn't have all this variability, because I really can't tell what's happening. And that EKG is really important. But even in that case, I'm telling you that you have some acute inferior changes. Okay, so he goes to the cath lab, et cetera, sorry. And he does end up having a right ventricular infarct. And I was so happy to see the note which said, do not diurese this patient. Do not give nitroglycerin. Do not give morphine. Patients having an RV infarct. Okay, now we're going to move to posterior, which is the end of our talk today. 15 to 20% of all STEMIs are posterior. Now, most of the time, we're going to see posterior infarcts as an extension of either the inferior, so that's RCA, or lateral, that's circumflex, okay? Normally, we're going to see it as an extension. But what that means is if you're having a lateral STEMI or an inferior STEMI and you have posterior involvement, you've increased by 150% the muscle mass that's being damaged. That's why the troponin goes up so much. And that's why those patients really do go into cardiogenic shock. And you're like, what? They had an inferior MI. How did that happen? Inferior MIs are supposed to do really well. Those shouldn't be so serious. Well, you've either infarcted the RV and or the posterior wall. Okay. Now, isolated posterior does occur. We've seen a few in the past few weeks here. It does occur. It's less common. It's more common to see infero-posterior, posterior lateral, or infero-posterior and lateral altogether. But occasionally you have just posterior. So I just want to remind you that what you are actually looking at here is mirror image. So we're just going to pretend, because I flipped this around and I had to manipulate it a lot, so forgive me. Just to remind you, if you have a STEMI in any wall, so in the inferior wall, the lateral wall, the anterior wall, or the posterior wall, what that means is you're losing a lot of muscle mass. That's going to present with ST segment elevation in the leads looking directly at the area. So if it's a posterior wall infarct, you would expect to see ST segment elevation on the posterior surface, but you're not looking at that generally. You're looking at the anterior surface for the reciprocals or the opposite. So what that would mean is ST segment depression in my V1, V2, V3, and maybe even into V4, and it only has to be one lead of that lead group that has ST segment depression. Doesn't have to be all those leads. One lead of that lead group with ST depression. ST depression in chest leads is always dangerous. And I want you to recall that what's happened is I have interfered with electrical rest. My R wave will be big on those V leads, those anterior V leads. My T wave will be upright, R wave upright, T wave upright, but I've got ST segment depression. That is really significant and impactful for how we're going to look at our patients. Okay, so we're always going to read the reciprocals and the anterior leads, the opposite changes. So you're going to have some really particular things that are really important. You're going to have a really big R wave, and it's going to be biggest in V2. That's typically where it's going to be the biggest. Your T waves will be upright. You have horizontal ST depression. That means not coving. You have a drop in your ST segment, and it's really a straight line. Horizontal ST depression, upright T waves, and a large R wave. So that's what's going to be really, really important. You can see that visual here. This is a posterior infarct seen in V1. Big R, horizontal ST, upright T wave. And if I was to do a posterior, this is V8, I would see a deep negative ST segment elevation and an inverted T, exactly opposite what I saw in my anterior lead. So whenever I see this in the anterior leads, I want to do a posterior evaluation. Now, to do a posterior evaluation, I've given you two different visuals, one without color, another with color, is I'm going to take off 4, 5, and 6, V4, V5, and V6, and I'm going to put them at the fifth intercostal space right here in these following positions. So exactly the same horizontal plane, actually looking at the scapula. So the tip of the scapula, V7, mid scapula, V8, end of scapula, V9. Okay. And just like with an RV infarct, all you need to see is 0.5 millimeters, 0.5 millimeter ST segment elevation. Any one of those leads actually now supports that your patient's had a posterior infarct. Again, this is not hard. Leads off to the right for right ventricular, leads off to the back for posterior. And all you're looking for, you're not looking at Q waves or T waves or anything else. All you're looking at is ST segment elevation, and it only has to be half a box, and it only has to be in one of those leads. Oh my gosh, how could that be easier? It's so fantastically fabulous. So now we look at it on a real model, and we just remind ourselves that if we have a posterior infarct, you can't see that directly from the front. You can only see it directly from the back, and it's far away from the back, which is why the ST segment elevation doesn't have to be that much, because we're far away from the heart. The heart is much more anteriorly placed. So in V1 and or V2, I'm going to have ST depression with upright T waves. If I put posterior leads on the patient, I'm going to have ST elevation, those posterior leads. Okay. So very common to see infero-posterior MIs, all the things we've already talked about. We're going to use V1 through V3 as a mirror image, showing us the opposite as an indirect, the opposite wall. Infero-posterior MI, here's my checklist. V1, V2, V3, any or all. Horizontal ST depression, yep, check. Tall, broad R wave, yep. And if you have been following me, you know I talk a lot about zone of transition. That means when the upright is bigger than the downwards, and we've transitioned here in V2, that's an early zone of transition. Tall, broad R waves, yep, check. Upright T waves, yep, check. Dominant R wave in V2, meaning more upright than downwards, yes, sir, check. That means I believe you're having a posterior MI. Now, at the same time, I'm telling you, you've got ST segment elevation lead 2, a little bit in lead 3, and in AVF. Okay, so that's really, really important. That's now correlating to where I think that lesion is, but who cares? All I need to do is get you to the cath lab. I put leads on your back, and this is an extraordinarily extraordinary ST segment elevation here. Normally, you don't see STs quite this big. This is V7, V8, V9. It took V4 off and put it on the back. V5 off, put it on the back. V6 off, put it on the back. And you have to mark it manually with your pen. It has to be written in the chart that that's what it is. And you can see you have significant ST segment elevation. That's a posterior MI. We'll look here at this patient. You can see I'm looking at this patient. He's got a little ST segment elevation 3 in AVF. That's enough for me to call a STEMI alert. But in addition, look at that ST segment depression, upright T wave. So again, not really horizontal depression, so kind of a half check there. Tall, broad R waves, absolutely. Upright T waves, absolutely. Great big R waves. That's very unusual on the right side, particularly when we look at V1, V2, and almost V3. Very significant. So check, 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 and check. This is a posterior MI. Here's another patient. So when you look at this patient, you say, oh, right away, you say, whoop, ST segments elevate 2, 3 in AVF, ST depression in 1 and L. Remember what Barbara said to you, whenever you've got an inferior, whenever you have a lateral. So this is acute STEMI inferior with lateral reciprocals. That means it's an RCA lesion. I'm going to still look at the posterior surface. I might also look at the right ventricle, but again, horizontal ST depression, upright T waves, and a big R wave. This is a posterior infarct. Here are the posterior leads, and this is more commonly what you'll see with posterior leads, just a little bit. This is like a millimeter of ST segment elevation that you see in V8 and V9. You didn't have anything in V7, you had it in V8 and V9, which is really the most common leads where you'll see ST segment elevation. Yet again, now this patient is a harder patient. This is a patient who will frequently get overlooked and told he has a cardiac arrest. Now that's really important. So you'll see in 2, 3 in AVF, he doesn't really have any ST segment elevation. In 1 in L, he doesn't have an ST segment elevation. In V6, he has a tiny bit, but it's less than a millimeter. And in chest leads, we don't worry that much about anything less than a millimeter. But here we are in V2. And in V2, he has horizontal ST depression. He has tall, broad R wave, upright T waves. He's actually having an isolated posterior infarct. And this is subtle, so it's easy to miss. A good attentive nurse is going to ask for a posterior EKG, but I don't have his posterior changes. What I do have, though, is the patient's cath. So what you're seeing here is that you have a significant stenosis in the left anterior descending as well as in the left circumflex. And that's of course what we would expect, because he had a little elevation in V6 and he had ST depression in V2, which was reciprocal to the posterior wall. I would anticipate that he had pretty significant ST segment elevation in his posterior wall. Okay, so again, sort of the same thing that we looked at before. Very isolated here, no real other changes, just that ST depression in V2. That's an isolated posterior. This patient, take a look at this poor patient. ST segment elevation 2, 3 in AVF, ST segment elevation in 1, not in L, but in 1, in 6 and 5, with ST depression in V1, 2, and 3. This patient is having an infralateral posterior infarct and will go directly to cardiac arrest or cardiogenic shock. He needs someone to intervene who really pushes fast and hard to get that patient to the cath lab. Here at Grady, this patient gets seen by EMS, by triage, by cardiology. He's not even going to be admitted into the ECC. He's going to go straight to the cath lab because we only have minutes to resolve for this patient. Okay, so on that patient, he did have a posterior EKG. And here you are, V7, 8, and 9. And again, this was really significant ST segment elevation. He's infarcting his whole inferior, posterior, and lateral wall. He'll have very little muscle left. He will leave the hospital. If he survives, he will probably leave the hospital in class 3 to class 4 heart failure. So that's really important. So now we come back and we say, what would you say to this EKG now? you've got a little ST segment elevation in 2, not any in 3, not really much in AVF, a little bit in 1, a little bit in V6, and ST segment depression really significant in V1, V2, V3, and V4. This is our patient. You would say now, this patient's having an acute posterior infarct. The other things are a little less clear, but this patient is having an acute acute posterior infarct. So remember what his initial 0 troponin was, 1.471, and then 1 hour later, greater than 26,000, okay? And here is his cath lab activation information. Everything was done really beautifully. He got to the hospital at 21:16. He did not have a STEMI alert from EMS, but once he was brought into the ED after they saw his first EKG, look at that. It's not even 30 minutes. It's a little longer than one would have liked for him to have his EKG earlier, would have liked it activated a little earlier, but still 30 minutes. And they activated the STEMI alert. Dr. Taha looked at the EKG, said, I'm coming. I'm going to get there as soon as possible. Patient had his troponin and his lactate level, and he went to the cath, and the patient received a thrombectomy and a PCI with a drug-eluting stent to the proximal left circumflex. So proximal means close to the bifurcation, putting at risk, really ultimately putting at risk the whole lateral wall as well as the posterior lateral surface. This was awesome. A beautiful catch, really well done. Yahoo for you. Very good work, everybody. Really good work. And that's what we would say to that EKG. But now I want you to look at the next EKG 4 hours later. Oh, sorry. This is his cath. So look at that. That's his circumflex, completely occluded right at the bifurcation here. So here's where you bifurcate into LAD, into circumflex from the left main. He's completely occluded, and that's post-stent. Look at that resumption of blood flow. Wowza, wowza, a really great job. And back to our patient 4 hours later, you can see he's really resolving his ST segments. His T waves are upright, does not have any ST elevation here, no more in V6, no more in lead 1. He stayed in the CVICU for about 36 hours, went to 5A, and is now discharged. So always really important to consider whenever you see Infero-MI, lateral MI, or a picture that's hard to diagnose but offers ST segment depression in V1, V2, V3, and V4, always, always, always consider that it might be posterior. Thank you very much. I'm really, really sorry. I don't have time for questions because I have CCRN review that begins at 5 o'clock. But I want to tell you, if you have any questions at all or anything you want to say, please email me, bmclean1@gmh.edu. Thank you, thank you, thank you for everything you do and for doing the right thing for patients and for attending today. And I hope many days. Tuesday, Wednesday, Thursday. I'll see you next week. Bye-bye for now.
Thank you, Barbara.